Good morning. Jim and I have broken this up into half and half. So Jim gets the first half, I get the second half. We come from, as you can see, an academic tradition. So our presentation is slides. We're going to go through the material very quickly, and then we invite anybody who has more interest in exploring further to come at 11:30, and we will explore further.
So if you're not really sure what residents are that Karen and I taught, they, after you...
You need the microphone.
Oh, after you, people go to college, then they go to medical school for 4 years, and then they have to do a residency before they're qualified to get a real job and go out there and pay off all those student loans that have been building up over the years. So Karen and I would work. She would come over one day a week, and when we had a behavioral clinic, and what we would do was watch the residents interact with the patients. We usually had either a psychiatric conditions or relationship problems, things like that. We saw kids as well. Anyway, they would we would observe them, and then they would come back and present the patients to us. That's basically how young doctors do it. Most of you know this, but just the difference between psychiatrists go to medical school for 4 years and then do a residency in psychiatry for 3 years, whereas PhDs usually get a master's degree and then you do a PhD, you have to do an internship, and you have to have so many supervised hours and things like that. So basically, to boil it down, psychiatrists and clinical psychologists do two things. They diagnose and treat. In order to when they diagnose, they have to come up with one of these over 300 different diagnoses, and the DSM stands for Diagnostic Statistical Manual. First one was 1952. The latest one is the DSM-5, which came out in 2013. This is my copy. This is the abridged version. This is Karen's. Cognitive capabilities, the differences. Anyway, I just say a little bit about how we've kind of divided up people artificially. We've decided that the body will go to the medical doctors. If they have some sort of spiritual problems, they go to a priest or a rabbi or whatever. And if they have problems, psychological problems, then they go to the shrinks, the psychologist or psychiatrist, which is really kind of artificial when you think about it. So there's been a movement, of course, to do things a lot more holistically, which is sometimes difficult to do. Anyway, the one way of trying to do that is to look at what contributes to people having psychological problems. Well, there's the biological part, there's the psychological, and then there's the social part. So each one of these contributes. Now, some particular disorders, like the brain disorders, obviously is a lot more biological. Some other disorders, it's a lot more the environment, stress, things like that. Now, this is just to show you how many people have various problems that would be considered a psychiatric diagnosis. But over half these folks aren't really getting the treatment that they need. Say less than a quarter of the people with mental disorders actually receive treatment from a mental health professional. So clearly that's a problem. One of the problems in deciding what goes into the DSM is changes, because as I said, it's been revised as we get more information. And this is what I think of kind of the 3 Ds. If a person's in distress, they have dysfunctioning, they're not able to really complete their roles as a mother or a worker or a student or whatever, or it's got to the point where they're a danger to themselves or others. And that are some of the descriptions or some of the reasons why a person would have a DSM diagnosis. None of these in themselves are enough really to be a psychiatric disorder. Now the causes are under biological, there could be genetics, medical conditions, brain damage, exposure to things like the lady mentioned about pesticides and so forth, contributing to either mental disorders or medical disorders. Traumatic life experiences, learned associations, distorted perceptions, which often happens with people with schizophrenia. They see things that aren't really there, they hear voices in their heads. And Karen will talk a little bit about faulty thinking when she does her part. And then there's the socio-cultural part as well. Now, one of the things that psychiatry especially has really focused on is chemical imbalances in the brain. And so we figured out that certain disorders relate to, say, low levels of serotonin, not enough dopamine, or too much dopamine in some cases. And this is really what we focused on. On the other hand, this is not the complete answer. Otherwise, we would have by now been able to come up with drugs that if you give the same drug to the people with the same disorders, they all would be cured, which is not the case. So clearly there's a lot that we don't know, and there's a lot that we have to figure out before we're going to be able to help every single person. Now, this slide just shows you the ones at the top are the disorders that we figured out that are really brain disease. Like, for example, Huntington's disease, we know it's on chromosome 3. Parkinson's disease, for example, is basically not having enough dopamine in your basal ganglia, which is kind of in the center of your brain. On the other hand, you don't want too much dopamine, because if you get too much dopamine in the mesolimbic system, you will have schizophrenia. So all of us probably have a balance of all these neurotransmitters, so we don't have these conditions. On the other hand, as I said, this isn't the complete answer. There are a lot of disorders, like, for example, eating disorders, which are really more psychological. I used to be able to say this, but it's not really true anymore, but like, I have to say, 40 years ago, people in Asia and Africa didn't have eating disorders, but now with Kentucky Fried Chicken and McDonald's being all over the world.
We've imported fat around the world, so be happy about that.
Oh, yeah.
Here's a big problem: stigma involved with mental illnesses and addictions and things like that. And I draw your attention to the middle one. That one's a really bad one, because people, if they have some psychological difficulties, they're thinking, oh, I'm a weak person, you know, John Wayne, he could get through this, but me, I'm such a no good Nick, you know, that's the reason I can't, you know, get all my work done and so forth. Say, for example, they're depressed. So we really have to get away from that, thinking of it as a characterological problem and not really a medical problem. So just to give you an idea how things have changed, we used to just put people in locked facilities if they were acting really strange. Bedlam is one of the first ones, and we now use that word. And then Freud came along and really kind of changed everything at the turn of the last century, because he came up with a talking cure. The idea that you could talk to people and they could talk about their past problems. Karen will talk more about this when she comes. And I just have to say, psychiatry has made a lot of big mistakes over the years. Here's some of the therapies that really caused a lot more harm than they did good. But the real change happened in the 1950s, when we started coming up with all these drugs, some of which are good and really do work, and then there are others that have a lot of side effects, really serious side effects. You kind of wonder if they're worth taking, considering the side effects. Like, say, for example, antipsychotic medications that can cause tardive dyskinesia, which is an irreversible condition of kind of lip smacking and so forth. And as somebody else already talked about, big pharma, all these pharmaceutical companies have a vested interest in coming up with as many diagnoses as possible, and they are, unfortunately, have too big of an influence on this whole pharmaceutical industry, and charge outrageous prices for drugs that really shouldn't cost that much. Now, what happened is we used to put people just in these locked facilities, And then people came up with the idea, once they were on medication, we could treat them as outpatients. So Kennedy signed the community mental health centers, and that was kind of the height of the treatment of mental disorders was back in the 60s. And over the years, funding for mental disorders has gone down, 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 down. And even though the Affordable Care Act says there's going to be equality between medical and psychiatric, that really probably, they've been promising that for years, that's really never happened. But it really made a big difference. As you can see here, this is a population of people in psychiatric hospitals has gone down dramatically. In fact, when I first moved to California, there were 33 psychiatric facilities in California. When we left, there were only 12. So they've been closing these, and these people have been supposedly treated in the community. Oftentimes, that does not happen. So even though it's a good idea, like for example at our hospital, if there was somebody on the wards with a psychiatric conditions, the nurses did not want to have to deal with these people. And even though there was a psychiatric facility, some of these people also had medical problems. So these are the people that will kind of fall through the cracks because there is no place for them. There are places in large medical centers that will do both. So this continuity of care hasn't occurred. These halfway houses were a good idea, but a lot of people didn't want them in their community. So only a small people were successful. A lot of them became victims, homeless, end up on the streets on drugs. They were incarcerated, easily duped. So a lot of interaction with police, and a lot of them have committed suicide or homicide. So about 1 out of every 4 Americans will experience psychiatric or psychological disorder in 1 year. A lifetime, it's almost 50%. So the big effort that we should be putting is we're figuring out now what causes mental disorders. We haven't really come to the, except for just a few of the diseases. Say, for example, some of them are very difficult to treat. We don't really have good medications for PTSD, post-traumatic stress disorder. And therapy helps a little bit, but not that much, because it's basically you damage the amygdala in the brain, and so that's not going to change because we don't grow new neurons. And there are others that we are really successful at, like for example, panic attacks. We know the medication is very successful, and basically it's just psychoeducation. You don't really need therapy. You just need to understand why they're having these panic attacks and take their medication. And then, as I said, the assessment is usually talking to the people to figure out what's going on with them. One of the things we don't do enough of is prevention. We don't do enough of that in medicine either, because you get a lot more bang for your buck if you try to prevent people from developing disorders than waiting until they have problems and then try to treat them. And that's the end of my section. This next section is Karen's going to do, and I just want to draw your attention to the reason I worked with young doctors for 30 years was the fact that when you look at the people who actually provide the therapy, usually people go to their family doctors first. Or an internist first, or a pediatrician first, or primary care doctors, because they're the ones that provide most of the care. And most of the psychotropic medication prescriptions are written by family doctors and internists, not psychiatrists. Okay.
Okay. So now we're going to talk a little bit about what is psychotherapy. Psychotherapy is the putting into practice of what we understand about psychology. So, throughout history, people have been asking the questions, who am I, why am I here, what's wrong with me, where do I come from? And there's a lot of cultural diverseness that takes us all the way back in history, so we have the early explorations of those questions in things like the meditative traditions and the oracles of Greece and spirit quests. But as we have played these out now in 20th century, 21st century America, and around the world. This is pervasive around the world now. Psychoanalytic theory, humanistic therapy, behavior therapy, and cognitive behavioral therapy are the four main tenets of how people get treatment. So that's what we're primarily going to talk about, is how do people get treatment and what exactly is it? So obviously the history, the big person in the history of psychotherapy is Freud, and Jim said he was the first person that introduced the idea of talking therapy. The one person before Freud was Mesmer, who, quote, mesmerized people. That was the starting of hypnosis, and the idea was that if you went into a trance, you could talk about whatever trauma that you'd had. That's really, really questionable at this point in time. When, I've done hypnosis. When I've used it with my patients. When you really hypnotize somebody, you're completely aware. Anybody who has, you don't go into a trance where you have no remembrance. That's just not what hypnosis is. It's a voluntary experience. And it's really a voluntary experience of just allowing yourself to let go. And anyway, Mesmer was the original person who talked about talk therapy. He didn't get a lot of play, really. Freud took over. So we are all familiar with the ideas of the id, the ego, and the superego. This is a wonderful little diagram, because what it really illustrates is how much of our process is not conscious. Most of us think that a lot of what we are and who we are and how we speak is conscious. Yeah. Sorry to disappoint you. Okay, so because mental symptoms reflect unconscious conflicts, they induce anxiety. I had anxiety coming in here to talk today. Anxiety is a normal part of life. We have anxiety when we go into a tough family situation. We have anxiety when we do something for the first time. We have anxiety when we do all kinds of things. The interesting part about Freud is that pretty much everything really is based on the idea of anxiety, the insight that you get from sharing your thoughts and your dreams with the person. Remember now, in psychoanalysis, you are laying on a couch. Is that true in today? No, most people don't have couches where, Freud, there was a couch out here, Freud sat back here. The person laid out on the Freudian couch, and Freud sat behind them, not looking at them, to get them to talk, free associate, dream interpretation, that kind of thing. But he did, at points, recognize that there was an alliance, this alliance between the therapist and the patient. And that it was that alliance that had something to do with the therapeutic process. So, he came up with the defense mechanisms of objective anxiety, neurotic anxiety, and moral anxiety. So the objective reality is, there's a bear at my door. The neurotic anxiety is, I'm afraid that there might be a bear at my door. And the moral anxiety is, if there is a bear at the door, am I going to open the door and take care of that scrawny old bear? Okay. So, realizing that defense mechanisms, we all have them. We all need them. They are important ways of how we function. The only time that defense mechanisms are bad, quote unquote bad, or destructive to how we function, is when we overuse them. There'd be a prime example of that person sitting in the White House. That person denies ever doing anything, and it's always somebody else's fault. That's a defense mechanism. I don't have the ego strength to take care of accepting responsibility for this, that, or the other thing. It's your fault. So the psychodynamic process, and I'm not diagnosing, by the way.
We are.
Although there is a whole cadre of our colleagues psychiatrists and psychologists who have gotten together and said, we are prohibited from diagnosing without treating, with whom we don't have a face-to-face with the patient, but they have gotten together. There must be like 80 or 100 psychiatrists and psychologists around the country who have all gotten together and diagnosed this man. Okay, so, yeah. Okay.
I want to see that website.
You all understand what he's doing. Okay.
Yeah.
Traumatic childhood experiences. So I have the traumatic experience. I develop a defense mechanism, i.e. forgetting or some other kind of picking at scabs or or having to walk through the doorway 3 times in each direction, it causes the symptoms that I have. In Freudian psychoanalysis, to remove that symptom, I lay on that couch and I do the free association, I report my dreams and stuff. And then this, by the way, is really hard for half of the people in the United States, or around the world probably, don't remember dreams. I'm one of those people. I remember maybe a dream or 2 a year. So psychoanalysis on a couch would not be my thing. Anyway, so, but those allow us to recover the forgotten material. With the awareness and the interpretation of the forgotten material, we can then remove the symptoms. Okay, following Freud, there was Carl Jung. Carl Jung is kind of the feel-good of the psychotherapeutic analytic community. What are you whispering about?
I said, Jung's my God. I hope you're not going to say anything bad about him.
No, he was a really good guy. He didn't think that everything that happened to us was sexual energy, which is what Freud did. So he developed divided the unconscious into personal consciousness and collective unconsciousness. So the whole idea of what archetypes were, that we all have some sense of who the mother is, who the hero is, who the male energy and a female is, or the female energy and a male is, and the shadow, which is the dark side of or the id. Karen Horney and Alfred Adler were people who came along as other psychoanalytics and looked at more into anxiety and superiority conflicts. Leaving psychoanalysis, we're going to go into behavioral therapy, classical conditioning, behavior attempts to change behavior using techniques of learning. So now we're not doing anything weird, we're actually looking at how does somebody learn? How does that 1-year-old learn? How does that 2-year-old learn? How do you and I learn? And we look at how we have learned things. Okay, so Pavlov's dog gets us from the unconditioned stimulus, which is the food, to the conditioned stimulus, which is the dog salivates when the bell gets rung. In practice, the kinds of behavioral therapies that we actually use are systematic desensitization, which is, we teach somebody how to become relaxed. Then we have them think about having to give that speech tomorrow. And the anxiety goes up, and you go, oh no, come back down, let's relax. We go back and do the relaxation exercises. And then we walk them through a hierarchy until they can maintain relaxation while dealing with this anxious thought. Aversive conditioning is things like put a rubber band around your wrist. Anytime somebody wanted to pick up that cigarette, snap the rubber band. That's aversive conditioning, but it really works for some people. Token economy is anybody who's raised a dog or a kid has done a token economy. Albert Bandura was the person who then talked about observational learning, how we learn from watching others. And that is really played out today in video gaming. There's been a tremendous amount of concern over the last 25 years about video gaming and what are our kids or people who video game actually learning, because it's observational learning. The father of modern cognitive behavioral therapy is Aaron Beck. Albert Ellis and Aaron came up with the same idea about that our thoughts influence our emotions and not the other way around. The Freudian model is that the emotions influence how we think. So the cognitive behavioral therapy takes it from the point of what we think influences how we feel. So the emphasis is on the present, not the past, which in other therapies it's on the analysis is on the past. Let's see. So
this is the therapy we teach the young doctors because it's very practical. You learn. It's a very easy model. You can learn it in, one session. So
yeah.
Speed up.
Okay. So cognitive therapy talks about these are the things, places where people get in trouble with their thoughts. For example, excessive responsibility, whenever anything goes wrong, is always my fault. You know, things aren't always your fault. So Beck had an idea about the negative triad, is what he called it, and that was, I have negative thoughts about myself, negative thoughts about the world, negative thoughts about the future, which cause me to be depressed. If I change those thoughts, then I will no longer be so depressed. So recognize the connections between cognitions, affect, and behavior, monitoring occurrences when these so I have to figure out when do I start distorting those ideas, when do I make those assumptions, why am I making those assumptions, and that's all done in relationship with the therapist. So this is Carl Rogers, yay, the father of humanistic psychology, good old Carl. So this is a wonderful quote from him. It says, in my early years, professional years, I was asking the question, how can I treat or cure or change this person? Now I would phrase the question as this, how can I provide a relationship which this person may use for his own personal growth? Rogers was the first person that really honed in on the idea that it's the relationship between the patient and the doctor that makes the therapeutic relationship work. It's the level of trust that we have. It's the positive self-regard, unconditional positive regard that Carl Rogers talked about, that if that makes you trust me, if you look at me and you say, I can trust you, you're going to tell me those ugly things about yourself that you don't like. And whereas most of the time, remember, we're really guarded with that persona thing. So the belief is natural and innate processes. He believed that, you know, we all seek to better ourselves. One of the things that we're all doing here at FOOF is we're all seeking to better ourselves. Intellectually, emotionally, spiritually, whatever it is, that's part of the reason why we're all here. So the solution is to be truly present and accepting. Unconditional positive regard. That's a really tough thing to do. Because I don't always like you. I didn't always like my patients. You know, they're just people. Some of them I liked, some of them I didn't. But to get out of that mode of me and to become this allowed you, whoever that person was, to see in me whatever you needed to see in me, to bring up what you needed to bring up. So how do we change our thoughts if we're not going through all of this stuff? Gratitude list, mindfulness, doing for others, spiritual practice. There are different types of psychotherapy, but they all aim to help you understand more about yourself, improve your relationships, and get more out of life. And Monty Python had it right. Try and be nice to people, avoid eating fat, read a good book every now and then, get some walking in, and try and live together in peace and harmony with people of all creeds and nations. Right on.